Hi, I'm Dr. Roger Blumenthal here with Dr. Seth Martin. We're both co-editors of the Dyslipidemia Community on Cardiosource. And Seth, welcome.
Thank you.
It's been a very fascinating meeting. We've had some nice presentations that talk about the future, but the future is still a long ways away for the outcome trials. Maybe you could tell the audience a little, Seth, about PCSK9 modulators, what they are, and some of your initial thoughts.
Absolutely, yeah. So we're years away, but the stage is set from these phase 3 trials that have been presented here. So PCSK9 inhibitors, it's really a sexy class of lipid modulating medications, and basically it works in a way similar to statins on the LDL receptor. The PCSK9 is a protein that degrades LDL receptors. So by inhibiting this, we basically allow a greater availability of the LDL receptor. And so what we're seeing from this, we've basically seen 5 phase 3 studies presented here at ACC 14, and they're they're remarkably consistent and robust in terms of showing that we're cutting LDL cholesterol in half or more. And this has been shown across a diverse set of populations, and the durability of the effect out to 52 weeks in the Descartes study. And these were all done with Amgen's evolocumab.
So in one of the studies, they compared it to ezetimibe, which has tended to be our go-to agent when people are completely statin intolerant. And in some of the other data they presented on top of high dose atorvastatin and rosuvastatin. Tell us, in one of the studies, I guess about 50% of the individuals had been intolerant of at least 2 statins. Maybe for our audience, we should clarify what we mean by statin intolerance, and clinically, what would you do, Seth, to see if a patient's really statin intolerant?
Yeah, it's a great question. GALS-2 was presented at the Late Breakers this morning, showing statin intolerant patients were able to really tolerate PCSK9 inhibition well. And so they had defined it based on at least intolerance to 2 statins. And some of the centers had even 3 or more statins that had been tried. And basically this was, it takes clinical judgment, but this is assessing patients closely after starting statins for symptoms that they're reporting, often myalgias, that leads to the discontinuation of statins, and the symptoms often go away with the discontinuation of statins. So in this population that can be tough and certainly an unmet clinical need right now, after we've really tried multiple statins and can't, as the guidelines would recommend, tried multiple statins and prioritized statins and can't seem to get the patient to tolerate it, this really could be a nice option, and seems to be well tolerated so far in the trials. So
we a lot of times we think about the statin intolerant patient as being very prone to side effects. And what was very nice in the GALS-2 is I believe they only had 8% of the individuals had muscle symptoms. So that's a very major step forward. Put on your guideline hat, put on your FDA hat. What do you think potentially could be the first indication for a PCSK9 inhibitor, assuming that we continue to see very good safety 3 years out? Do you think that in the statin intolerant group, or people who have familial hypercholesterolemia, would they be groups that potentially could get some limited indications for use?
I think that's right. It seems to me that, I mean, much more senior people could talk better to this point, but it really seems like the slam dunks would be those statin intolerant patients, as well as the heterozygous FH population that's being tested in the trials that would be the highest priorities for this class of medications. I think the grayer areas will be patients that don't necessarily meet those conditions but have severe hyperlipidemias and are already tolerating good doses of statins. And I think if we get the outcomes data in these phase 4 trials, and I'm very hopeful, I'd be shocked if we don't see that, because the biology is so intact, the epidemiology, and now the trials are looking so good. But so I'm very, very hopeful that even in broader populations, this could still be a useful class of medications for those patients who still aren't quite where they need to be.
So we should remind our audience that these are subcutaneous injections. If you took this monoclonal antibody orally, it would get broken down in the GI tract. Yeah. But we have so many patients that are diabetics that give themselves injections. Yeah. So I think that's very important. What is your feeling about what needs to be done in terms of anacetrapib, the CETP inhibitor, since we've had 2 of the CETP inhibitors not work out well? How do you think regulatory agencies will look at that?
Yeah. There, I think the outcomes studies are just as, and probably actually much more important, given the complexities of the biology there and the outcome studies we've had so far. But certainly there's differences, it seems, between anacetrapib and the other CETP inhibitors. So I think in the next years to come, it's going to just be exciting. We've had a lot of failures in the lipid trials in the last several years. So I think it's nice for us all to have these trials where we have a lot of hope, and we'll see what we find. But I think these could be a very warmly welcomed therapeutic option.
And that'll be great. It'll give Dr. Stone and his panel some other things to consider once we get some more clinical trial data. So this is Dr. Roger Blumenthal and Dr. Seth Martin, the editors of the Dyslipidemia Community on CardioSource. Thank you very much for joining us today.